So, good day. We are the Group 6, and today we're going to talk about the drugs affecting the immune system. So, our system is a complex fighting system powered by 5 liters of blood and lymph. So, a fun fact about our immune system our immune system remembers every microbe it has ever fought and defeated. So it means that if a microbe enters the body for a second time, the immune system has stored record that enables it to quickly recognize and fend off the microbe before it has the chance to infect you. So first, what is immune modulator? As stated here, immune modulators are used to modify the actions of the immune system. We have here the immune stimulants and immune suppressants. What are immune stimulants? Immune stimulants are used to energize the immune system when it is exhausted from fighting prolonged invasion or when the immune system needs help fighting a specific pathogen or cancer cell. Next one, we have our immune suppressants. These are used to block the normal effects of the immune system in case of organ transplantation, in which non-self cells are transplanted into the body and destroyed by the immune reaction. And in autoimmune disorders, in which the body's defenses recognize self cells as foreign and work to destroy them in some cancers.
So, what are the categories of immune stimulants? So, they are the interferons, the interleukins, and colony stimulating factors. So, interferons are naturally released from human cell in response to viral invasion. So, what are the agents? Interferons alpha 2b or intron A, interferons alpha 2A Pegasus, interferon beta 1b, betaseron, interferon beta 1A or Avonex, interferon alpha con 1 Impergen, peginterferon alpha 2b, peg intron, interferon alpha N3, alferon N, and interferon gamma 1b, act immune.
Therapeutic actions and indications. Interferons act to prevent virus particles from replicating inside cells. They also stimulate interferon receptor sites on non-invaded cells to produce antiviral activity, which prevent viruses from entering the cell. In addition, interferons have been found to inhibit changes and adaptation to stimulate cytotoxic activity and to enhance the inflammatory response. Of interest, interferon gamma acts like an interleukin, stimulating phagocytes to be more aggressive through useful indications for each interferon.
Next is pharmacokinetics. The interferons are generally well absorbed after subcutaneous or intramuscular injection. They have a rapid onset of action and peak within 3 to 8 hours, with a half-life ranging from 3 to 8 hours with the exception of interferon beta 1A, which has an onset of action of 12 hours and reaches peak levels in 48 hours, with a half-life of 10 hours. They are broken down in the liver and kidneys and seem to be excreted primarily through the kidneys.
Let's proceed to the contraindications and cautions. The use of interferons is contraindicated in the presence of known allergy to any interferon or product components to prevent hypersensitivity reactions. Many of the interferons are teratogenic in animals and therefore should not be used during pregnancy. Use of barrier contraceptive is advised for women of childbearing age. It is not it is not known whether these drugs cross into breast milk, but because of the potential adverse effects on the baby, it is advised that the drugs not be used during lactation unless the benefits to the mother clearly outweigh any risks to the baby. Caution should be used in the presence of known cardiac disease because hypertension and arrhythmias have been reported with the use of these drugs. with myelosuppression because these drugs may further suppress the bone marrow, and with central nervous system dysfunction of any kind because of the potential for CNS depression and personality changes that have been reported.
So next is the adverse effect. So it's associated with the use of interferon are related to immune or inflammatory reaction that is being stimulated. So other commonly seen adverse effects include headache, dizziness, bone marrow depression, and suicidal ideation, photosensitivity, and liver impairment.
Important drug-to-drug interaction. There are no reported clinically important drug-to-drug interaction with the interferons.
Number two,
Ulitin.
interleu- interleukins are chemicals produced by T cells to communicate between leukocytes. The agents include is aldesleukin or proleukin, oprelvecin or Numega.
Next is the therapeutic action and indication. Natural interleukins 2 is produced by various lymphocytes to activate cellular immunity and inhibit tumor growth by increasing lymphocyte numbers and their activity. When interleukins are administered, there are increases in the number of natural killer cells and lymphocytes. In cytokine, activity and the number of circulating platelets.
So let's proceed to its pharmacokinetics. So the interleukins are rapidly distributed after injection. Aldesleukin given for reaches peak levels in 30 minutes and has a half-life of 85 minutes. Oprelvecin, which is given subcutaneously, reaches peak levels in 3 to 5 hours and had a half-life of 7 to 8 hours. So they are primarily cleared from the body by the kidneys.
So the next one is the contraindications and cautions. So interleukins are indicated in the presence of any allergy to an interleukins or E. coli produced product to prevent hypersensitivity reaction. So because they were shown to be embryonical and teratogenic in animal studies, they can be used during pregnancies. Use of various contraceptives is recommended for women of childbearing age who requires one of these drugs. It is not clear whether the drugs cross into breast milk, but is recommended that they can be used during lactation. So it if they must be used, another method of feeding the baby must be chosen because of the potentials for adverse effect in the baby. Fusion should be used with renal, liver, or cardiovascular impairment because of the adverse effect of the drug.
The adverse, the adverse effects of interleukins can be attributed to their effects on the body during the inflammation, respiratory difficulties, CNS changes, and cardiac arrhythmias also has been reported, and the patient should be monitored for the effects and the drug stop if they occur. Oprelvecin has been associated with severe hypersensitivity.
The clinically important drug-to-drug interactions. There are no reported drug-to-drug interactions with the interleukins.
Next is the colony stimulating factors. This is used to stimulate the bone marrow to produce more white blood cells in situations where the levels of these cells are very low and the patient is at serious risk for infection. Agent: filgrastim, neopogen, pegfilgrastim, neulasta, sargrasmostim, lidocaine.
So let's proceed to the therapeutic actions and indications of colony stimulating factors. By increasing the production of white cells, the colony stimulating factors can be used to reduce the incidence of infection in patients with bone marrow suppression. So, to decrease the neutropenia associated with bone marrow transplants and chemotherapy, and to help in the treatment of various blood related cancers.
Next is the pharmacokinetics. Filgram- Filgrastim can be given IV or by subcutaneous injection, reaching peak levels in 2 hours, IV or 8 hours subcutaneously. It has a half-life of about 220 minutes, duration for 4 days, and its metabolism and excretion are not known. Pegfilgrastim is only given by subcutaneous injection with similar onset but has a much longer half-life, 15 to 80 hours, than filgrastim. Sargramostim can be given IV or subcutaneously with a duration of 6 hours or 12 hours subcutaneously. It has a half-life of 1 to 3 hours and its metabolism and excretion are not known.
So the next one is the contraindications and exclusions. So interleukins are contraindicated in the presence of any allergy to any components of the drugs or the equally produced product to prevent hypersensitivity reaction. Sargo- sar- Sargrasmostism is contraindicated in the neonates because of the benzyl alcohol in the solutions, and with excessive leukemic myeloid blast in the bone marrow or peripheral blood, which could be worsened by the drug. This drug should be used with caution in pregnancies and lactation because the potential effect on the fetus or the neonate are not known. Sargrasmostism should be also used with caution in hepatic or failure, which should alter to the pharmacokinetics of the drug. During or immediate after radiations or chemotherapy because of its potential loss of effectiveness.
The adverse effects of associated with colony stimulating factors are gastrointestinal effects like nausea, vomiting or diarrhea, headaches, fatigue, generalized weakness and alopecia, and dermatitis, and the generalized pain and bone pain. The effects are thought to be associated with the drug's effects on the bone marrow cells and their increased activity.
The only reported drug-to-drug interactions associated with these drugs is an increase in the myeloproliferative effects of sargramostim when combined with lithium or corticosteroids. This combination should be used with caution.
Next is the nursing consideration for patient receiving immune stimulants. First is assess for contraindications and caution. Known allergies to any of these drugs of their component to prevent hypersensitivity reactions. Current status related to pregnancy or lactation to avoid serious adverse effects on the fetus or baby. Next is perform a physical assessment to determine baseline status before beginning therapy and for any potential adverse effect. Inspect for the presence of any skin lesions to detect early dermatological effects. Obtain weight to monitor for fluid retention. Monitor temperature to detect any infection. Check heart rate and rhythm and blood pressure to monitor for any cardiac effects of the drug. And assess level of orientation and reflexes to evaluate CNS effects of the drug. Next is obtain a baseline electrocardiogram if appropriate to evaluate cardiac function, and monitor adverse effects of the drugs. Assess patients' renal and liver function, including renal and liver function tests. This is to determine the appropriateness of therapy and to determine the need for possible dose adjustment and toxic drug effects. Lastly is to monitor the results of laboratory tests such as complete blood count to identify changes in bone marrow function.
So here are some nursing diagnoses that can be used. Um, Related to drug therapy, that it might include first acute pain related to CNS, gastrointestinal, and flu-like flu-like effects. Okay. Imbalanced nutrition, less than body requirements related to flu-like effects. Third is anxiety related to diagnosis and drug therapy. And lastly, deficient knowledge regarding drug therapy.
So next is we go to the implementation with rationale. Number one is to arrange for laboratory tests before and periodically during therapy, so including CBC and differential to monitor for drug effects and adverse effects. Next one is to administer drug as indicated, instruct the patient and the significant other if injections are required to ensure that the drug will be given if the patient is not able to administer it. So monitor for severe reactions such as severe hypersensitivity reactions and arrange to discontinue the drug immediately if they occur. Arrange for supportive care and comfort measures for flu-like symptoms like rest, environment control, to help the patient cope with the drug effects. Ensure that the patient is well hydrated during the therapy to prevent severe adverse effects. Instruct female patients in the use of barrier contraceptives to avoid pregnancy during the therapy because of the potential for adverse effect on the fetus. Offer support and encouragement to deal with the diagnosis in the drug regimen. Provide patient teaching about measures to avoid adverse effects, warning signs of problems, and proper administration technique.
Next one is the evaluation. The first one is monitor the patient's response to the drug, monitor for adverse effect, evaluate the effectiveness of teaching plan, monitor the effectiveness of comfort measures and compliance with the regimen.
So now, let's proceed to the immune suppressant categories. So there are categories of immune modulators, T and B cell suppressors, interleukin receptors antagonists, and monoclonal antibodies. So in the first category, there are immune modulators that it blocks the release of the virus cytokines involved in the inflammatory response and activation of lymphocytes, decreasing immune activity.
The therapeutic actions and indications of immune modulators have a number of effects on the inflammatory system. Lenalidomide and thalidomide inhibit the secretion of pro-inflammatory cytokines and increase the secretion of anti-inflammatory cytokines from monocytes and have varying effects on cell proliferation. Fingolimod inhibits the release of lymphocytes from lymph nodes into the peripheral blood so they cannot migrate to activate immune and inflammatory reactions. Fing- Fingolimod is the first oral agent for the treatment of relapsing forms of multiple sclerosis. Lenalidomide is used in treating multiple myeloma and myelodysplastic syndromes. Thalidomide is also used for treating multiple myeloma and erythema nodosum leprosum.
Next is pharmacokinetics. Fingolimod is slowly absorbed from the gastrointestinal tract, reaching peak levels in 12 to 16 hours. It is metabolized in the liver and excreted through the kidneys with a half-life of 6 to 9 days. Lenalidomide is absorbed quickly from the gastrointestinal tract, reaching peak levels in 30 to 90 minutes. It is excreted unchanged in the urine with a half-life of 3 hours. Thalidomide is very slowly absorbed from the gastrointestinal tract, reaching peak levels in 3 to 6 hours. The metabolism of thalidomide is not known. It is excreted in the urine with a half-life of 12 to 24 hours.
Let's proceed to the contraindications and cautions of immune modulators. All of these drugs are contraindicated during pregnancy because their effects on cells can cause serious fetal harm. Women of childbearing age should be advised to use barrier contraceptives when using this drug, and proof that the patient is not pregnant needs to be documented in the chart before beginning therapy and periodically during therapy.
So next one is T and B cell suppressors. So several T and B immune suppressors are available for use of the numerous agents available. Cyclosporin is the most commonly used immune suppressant.
So the therapeutic actions and indication, the exact mechanism of actions of the T and B cell suppressor is not clearly understood. It has been shown that that they block antibody production by B cells, inhibit suppressors, and modify the release of interleukins and T cell growth factor.
So let's proceed to the pharmacokinetics. The, the cyclosporine is ulit, ulit. Let's proceed to the pharmacokinetics. Cyclosporine is well absorbed from the GI tract, reaching peak level in 1 to 2 hours. It is extensively metabolized in the liver by the cytochromes P450 system and is primarily excreted in the bile. The half the half-life of the drug is about 19 hours for Sandimmune and 8.4 hours for the neural. It is available as an oral solution that can be mixed with milk, chocolate, and orange juice for ease of the administration.
Next is the contraindications and cautions of T and B cell suppressors. In the presence of any known allergy to the drug or its components to prevent hypersensitivity reactions and during pregnancy and lactation, because of the potential serious adverse effect on the fetus or the neonate. Caution should be used with renal or hepatic impairment, which could interfere with the metabolism or excretion of the drug, and in the presence of known neoplasm, which potentially could spread with immune system suppression.
The adverse effects of these drugs are patients receiving these drugs are at increased risk for infection and for the development of neoplasm due to their blocking effect on the immune system. Other potentially dangerous adverse effects include hepatotoxicity, renal toxicity, renal dysfunction, and pulmonary edema. Patients may experience headache, tremors, secondary infections such as acne, GI upset, diarrhea, and hypertension.
One is the therapeutic actions and indications. So anakinra specifically antagonizes human interleukin 1 receptors, blocking the activity of interleukin 1. Interleukin 1 levels are elevated in response to inflammation or immune reactions and are thought to be responsible for the degradation of cartilage that occurs in rheumatoid arthritis. Anakinra is used to reduce the signs and symptoms of moderately to severely active rheumatoid arthritis in patients 18 years of age and older who have not responded to the traditional anti-rheumatic drugs.
So the next one is a pharmacokinetics. The recommended dosage is 100 milligram per day by subcutaneous injection. Anakinra is administered by subcutaneous injection and it's absorbed slowly. Reaching peak effect is in 3 to 7 hours. It is metabolized in the tissue with a 4 to 6 hours half-life and is excreted in the urine.
So anakinra is contraindicated with any known allergy to E. coli, produced products, or to anakinra itself to prevent hypersensitivity reactions. It should be used with caution during pregnancy and lactation. Because the drug may cross the placenta and enter breast milk, it is also used cautiously in patients with renal impairment, immunosuppression, or any active infection because this could be exacerbated by the effects of the drug. There is an increased risk of infection whenever the drug is used, and the patient needs to be protected from exposure to infections and monitored closely after any invasive procedures. Immunization cannot be given while the patient is on this drug.
So the adverse effect is headache, sinusitis, nausea, diarrhea, upper respiratory and other infections, and injection site reactions are among the most common adverse effects.
The clinically important drug-to-drug interaction. Patients who are also receiving etanercept must be monitored very closely because severe and even life-threatening infections have occurred. Anakinra should not be combined with abatacept because of the potential for serious infections.
Let's proceed to the last category of immune suppressants, which is the monoclonal antibodies. So, these antibodies attach to specific receptor sites that are being developed to respond to every specific situations. Therapeutic actions and indications. Mor- Moromonab CD3, the first monoclonal antibody approved for use, is a T-cell specific antibody that is available as an IV agent. It reacts as an antibody to human T cells, disabling the T cells and acting as an immune suppressor. Next.
Pharmacokinetics, with the exception of erlotinib, an oral agent, of all the monoclonal antibodies have to be injected. They can be given IV, IM, or subcutaneously. Because antibodies are proteins, they're rapidly broken down into the gastrointestinal tract. They are processed by the body like naturally occurring antibodies.
So the next one is a contraindications and cautions. So monoclonal antibodies are contraindicated in the presence of any known allergy to the drugs or to urine products to prevent hypersensitivity reactions and the presence of fluid overload, which could be exacerbated. They should be used cautiously with fever and in patients who had previous administrations of monoclonal antibodies. Because of the potential for adverse effect, they should not be used during pregnancy or lactation unless the benefit clearly outweigh the potential risk to the fetus or the neonate.
So let's now proceed to the clinical importance of drug-to-drug interaction. Use caution and arrange to reduce the dose of a monoclonal antibody in combined with any other immunosuppressant drug because severe immune suppression with increased infection and neoplasm can occur.
So next is the nursing consideration for patients receiving immune suppressants. First, assess for contraindications and cautions. Second, perform physical assessment to determine baseline status before beginning therapy and for any potential adverse effects. Next is obtain a baseline electrocardiogram to evaluate cardiac functions. Assess the patient's renal and liver function, including renal and liver function tests to determine the appropriateness of therapy. And lastly, monitor the results of laboratory tests.
Nursing diagnosis. Nursing diagnosis related to drug therapy might include acute pain related to CNS, GI, and flu-like effects, risk for infection related to immune suppression, imbalanced nutrition less than body requirements related to nausea and vomiting, deficient knowledge regarding drug therapy.
Here are some implementations with Rationale. So first, arrange for laboratory tests before and periodically during therapy, including CBC, differential, and liver and the renal function tests to monitor for drug effects and adverse effects. Administer the drug as indicated. Instruct the patient and a significant other if injections are required to ensure proper administration of the drug. Protect the patient from exposure to infections. Arrange for supportive care and comfort measure for flu-like symptoms. Third, fifth is monitor nutritional status during therapy. Provide small frequent meals, mouth care, and nutritional consultation as necessary to ensure adequate nutrition. Instruct female patients in the use of barrier contraceptives to avoid pregnancy during therapy because of the risk of adverse effects to the fetus. Also, suggest another method of feeding the baby if a woman is nursing while on these drugs because of the potential for adverse effects on the baby. Other support and encouragement to help the patient deal with the diagnosis and the drug regimen. Provide thorough patient teaching. And then lastly, offer support and encouragement to help the patient deal with the diagnosis and the drug regimen.
Next is we have the evaluation. So monitor patient response to the drug. And then next one is to monitor for adverse effect. Evaluate the effectiveness of the teaching plan. And last one is to monitor the effectiveness of comfort measures and compliance to the regimen.